Oh, hi. It's Frances. I'm doing my pain management and alternative therapies lecture. So, this is a good one for us to do because we talk about a lot of different stuff. We talk about meds that can cause addictions. How do you help people that have a lot of pain? Talk about how people experience pain. And you can see on this first slide, we have this Baker-Wong or Wong-Baker pain scale for people that can't necessarily verbalize that they have pain, but they can point to a face and let us know what they're dealing with, because we need to be able to help everybody, not just the ones that can tell us what's going on. Pain vocabulary to know. Adjuvant. We're going to talk more about that in oncology. Allodynia. Look it up. You should know that word. Analgesic. Equianalgesic. Hyperalgesia. And nociceptors. So these are all good terms to use if you want to talk like a provider, all fancy like, and they're just good to know because some people will use these in their notes, and so it's good to know what these words mean. Looking at neurochemicals of pain, we're going to focus on 4 of these essentially. For pain initiators, the ones that get pain going, tell the brain what's up, you have substance P centrally, that's talking to the brain. And then peripherally, we have prostaglandins, and I know you've heard of those before. And then for quieting pain down, we're going to talk about endorphins, and we're going to talk about serotonin, especially when we talk about alternative therapies. So substance P is a neuropeptide that helps to initiate pain. It talks to the brain through the spinal canal, and it says, hey, we're having pain here. Opioids can actually block substance P. It's just something that's good to know. And you can also use ketamine and methadone because they're also antagonists of the NMDA receptors, so they can also block pain sensation. And pain is about perception and about modulation. So perception, there's a baseline that all humans generally have. There are kids, I've seen them in my clinic, who seem to have like no pain perception at all. They don't seem to experience pain, especially like some of my more severe autistic kiddos that I was seeing in my clinic. And then eventually, they start to notice that it doesn't feel as good to hit my head all the time. And it takes a couple years for them to start noticing pain. So perception of pain, there's a baseline for everybody. We all have our own way of dealing with it when it does show up. Modulation is the body's ability to either quiet or increase to help communicate the severity of the situation, but it's also one of the reasons why people are perceiving pain differently. So it's important to remember that, to know that distinction, because pain is whatever the patient says it is. And that's by somebody named Margot McCafferty. So I use that in my practice. I'm like, hey, if you're having pain, tell me all about it. And this person might have like a little blister they're complaining about. Well, that guy has a broken femur and he's not talking about his pain nearly enough compared to the other one. So you just have different people's experiences, but we all have to honor the experiences that our patients are having. So is the following statement true or false? Endorphins represent the same mechanism of pain relief as a non-narcotic analgesic. So are endorphins the same thing as like an ibuprofen or a Tylenol? What do you think? False. So endorphin release inhibits the transmission of painful impulses. That's not what happens with our prostaglandin inhibitors. Endorphins protect us from pain, which is different than taking a medication for it, because a medication might look at pain receptors, but it might also deal with inflammation, things like that. An endorphin is what gets us out of the fight with the bear. It blocks the pain, it gets us so that we can run away, and then we're going to experience our pain when our adrenaline, our endorphins start to decrease. So that's one thing to really remember, is that everybody's endorphin system is different. So therefore, their sensitivity to pain is highly individualized. So you can't disregard one person and only listen to another person. You have to listen to everybody, because this is what hurts one person might not affect another person. And we even see that probably in our own families, where like one sibling, you can just beat on them all day long, whereas the other sibling will cry as soon as they even get touched. Yeah, I was the crier. Okay, so remember, pain is the 6th vital sign. It's something that's important to remember. It's to our detriment. We can talk about that in person one day. Are we focusing too much on pain? Is that why the opioid crisis happened? We'll talk about it at some point. But you also want to remember from back when you were first starting in this program, what are some of the vital sign changes that you see when someone is having pain? Even if they're not even talking about it, you might see their heart rate go up. You might see them become hypertensive. And you might even see their oxygen level go down, especially if they're guarded and not taking in big, good breaths. You might see that their oxygen levels start to decrease. And like we already talked about, you have the restless folks that are in pain that might say a lot about it, are on the call light all the time, crying, constantly moving because they're so uncomfortable. And then you have the silent sufferers, the stoics, who sit there, are guarded, almost like paralyzed, because if they move, the pain's so intense, but they don't always tell us about that. We have to open those conversations up, no matter which one they are. And then types of pain, you can get this from the table in the book, 11.2. We're looking at acute, so it's kind of new. We're trying to figure out what's causing it. Chronic, we probably already know what's doing it. It's probably just going to be part of their life until we can correct the problem, if that's even possible. Neuropathic pain, which is problems with the nerve system and the tissues of the nerve system. We're looking at visceral pain, which would be the hollow organs. And generally visceral pain, we don't know it's our stomach that hurts or our appendix that hurts. It hurts someplace else. And us as medical practitioners have to kind of have an idea of like, oh, if the umbilical area, umbilicus or belly button is hurting, I'm going to do this thing with the right leg and see if it could potentially be the appendix. So where the pain is referring to helps me figure out what's going on and help the patient. And then breakthrough pain, which is generally with chronic pain. It's where you can keep the pain at a certain level, but eventually it breaks through. It happens. And these are slows 2, 3, and 4. So on this side, I put in a lot of the hospital pain scales. So you see the Wong-Baker Faces one. We have the 1 through 10. You see the nonverbal pain scale as well, where you're looking at your patient, you're taking in information that they're giving you, sounds, movements, etc. And you're trying to figure out, are they in pain? Do I need to treat it? Because they can't tell me. And then this other image in the middle is the one I used in child neurology, where nerves of the spinal cord actually correspond to different areas on the skin and the muscles. So I could use that to figure out if someone had an impinged nerve, like in the neck, or if they're having problems with their back. I used it a lot. And the assessment of pain is really the main takeaway on this slide. So you're going to use that PQRST again. You have to start off with knowing where the pain is. And then you talk about the precipitating factors. Why did this come on? What were you doing? When you cough, when you walk. You're going to talk about the quality of the pain. And you're going to understand, is it soreness? Is it achy? Is it sharp? You're going to do radiation of pain. Now, the radiation of the pain is it going somewhere else? Does it start in one place and start moving? The severity, which is what all of our scales are for. And then the timing. Is it intermittent? Is it constant? These are all important things to know before you call the doctor. So the physiological basis for pain relief, We're talking about three different things here: the opioids, the NSAIDs, and the local anesthetics. So remember, the opioids act on the central nervous system. NSAIDs tend to act on the peripheral system, and then local anesthetics will block actual nerve conduction. Neuropathic pain, that's when you hear your patients talking about tingling, burning. Remember the hormigas we've talked about? Numbness, and even like electric shocks. It can be very painful, and it can be numb, which is also disconcerting because then you don't know if something's wrong. And this is where the nerves are actually damaged. And it can be mild, it can be severe. If it's in the feet, when you start walking, it gets worse. And we have some alternative therapies that are very useful. Gabapentin, clonidine can help. We give a lot of gabapentin. I'm sure all of you have given gabapentin. And this is where that word allodynia comes in handy, because what it is like an odd perception of a pain, something that causes a lot of pain that shouldn't cause a lot of pain, normally doesn't. And that's where that word comes in here. And this is slow number 2. Factors that influence pain response, of course, past experiences. You can have a lot of trauma around pain, so any little bit of pain can really register very emotionally for some people. Anxiety and depression can increase or decrease pain. Culture, of course, age, and then gender. I don't know how I feel about that one. I think the more people you treat in your practice, the more you're going to realize that gender may not have as much to do with it. It's more about the person and their personality. This question: what is the time frame for pain that can be classified as chronic? What do you think? The answer probably is B, 2 to 3 months. In some cases, we may wait until 3 to 6 months, but so B should probably be the best answer for this one. Chronic pain has been there for a while. Gerontological considerations with pain. So remember that polypharmacy. Our older patients, generally on lots of different medications, which can affect any other medications we give them, especially for pain. They're usually pretty opioid naive if they're not a common, a pain sufferer. They might be really sensitive to pain, and therefore we have to remember that even though we're giving them maybe an opioid, that maybe other drugs they're taking could increase how much opioid is in their system or decrease. And then on top of that, their kidney function, their liver function, all the things that are helping us metabolize and excrete something could be off because of age or damage or other medications. And older folks are likely to have a lot of GI issues with NSAIDs. So we have to be careful with NSAIDs use with our GI, our gerontological population. And this is slow number 10, as well as this one. So if you are looking at this, you might see meperidine at the bottom. We don't really use that anymore. That's Demerol. That used to be the drug for pregnant moms back in the day. It's an opioid. We don't use it very much anymore. It caused a lot of hallucinations. So you can disregard that one. Codeine might be a good one to start with. If you're asking your families, like, what is your pain? Have you tried NSAIDs? Oh, you shouldn't eat oh, okay, because you're on, this anticoagulant, maybe we shouldn't give you that one. Maybe let's try an opioid then. So you can start with codeine, because codeine does change over to morphine in the system. It's very mild. And they can actually sleep with it too. And, that's one that you can kind of ease in, see how they do with opioids, see if you need to step it up or not. It's a good place to start. And then dosing, of course, a lot of times it's just as needed, that PRN dosing. And we try to get them to take the oral ones if possible, because we know that they last longer, and we'll talk about that in a little bit. But if they are like a post-op patient, something like that, they might be around the clock. Pain medicine takers, So it's okay to wake those folks up. You're going to want to make a plan with them, especially if they're not post-op. Do you want me to wake you up when the 4 hours is up and I can give you that Norco again? Something like that. And you can taper those doses when we've got them up and moving. They're a couple days after surgery. We can start seeing if they still need that level of pain control or if we can start to break them down, because that's one of the things we have to consider is we have to send them home and we can't give them IV meds at home. So we have to get them on orals in order to get them out the door, generally speaking. One of the things to remember is that when you're looking at your MAR and you have a patient who may be reacting to an opioid that you're giving them, when you're looking at the anti-nausea meds, they usually will be numbered first line, second line, third line, and generally goes first line on Dancitron, Zofran, second line is the Reglan, and then third line would be Compazine. And if one's not working within a half hour of giving it, you can try the next one. You don't necessarily have to wait so much. You have to wait in between doses of the same med, but trying a different med, you can go ahead and try it out without having to wait too long. And it's okay to give anti-nausea meds with an opioid. The best thing to do, especially if it's a PO opioid and they tend to have some of it, you definitely want to maybe request a smaller dosage unless their pain is not controlled, in which case maybe an anti-nausea med 20 minutes before you give the PO opioid would be very helpful, because then you can deal with their nausea and you can deal with their pain. So it'd be very helpful. Administration routes, of course, transdermal. It's a lot of fentanyl patches. If you want a good book, you should read this book called Demon Copperhead. It talks a lot about the opioid crisis in, I think it's West Virginia or Tennessee, somewhere like that. And they know how to cook the patches in this. I learned a lot reading this book. It was a very good book. So fentanyl patches, you have to be very careful with them. You can't put like heat on them or anything like that, because then they'll disperse faster. You have your parenteral routes, your PO routes. They're saying it's best for breakthrough pain. In the hospital, you're usually going to see IV doses for breakthrough, but out in the regular world, I think PO is going to be better for that. You have your epidurals, which are very potent. We'll talk about that a little bit more. You're going to have your nerve block pumps, like OnQ, where you have a very fixed flow until the pump runs out, essentially. And then your PCAs. There's a lot of different ways to give these meds. This is your slow number 5. So an analgesic ceiling, which we're going to learn about in a sec, is something that you have with these non-opioids. So you have acetaminophen, which is, of course, great for fevers, for mild pain. Even in the hospital, you can get it IV. I don't know if you remember those bottles. I have a picture of it later in the presentation. It's called Oframev. You have to like put it upside down. You have to like spike it. It's a glass bottle. It's pretty cool. You have PO and you have parectal. So remember, if they're not tolerating anything, PO, and for whatever reason you don't have IV, you can give it rectally. And then you also have your NSAIDs, like your naproxen, your ibuprofen, your Toradol. We're going to talk about those a little bit more. But here's the thing. You need to know these considerations. For these NSAIDs, bleeding, GI bleeds, GI ulcerations, very common, especially with the gerontological crowd. So make sure that you remember that, okay? Non-opioids, there's that analgesic ceiling. So it's like where you get to the highest point where you don't get any additional relief of your pain with more of that medication. So it's kind of like this is the top dosing to get pain relief. And after that, you might end up having some bad side effects. Consequently, opioids tend to have no analgesic ceiling, and we'll talk about why that's problematic. However, these ones you don't get really addicted to. I mean, I'm sure somebody is addicted to ibuprofen out there, but it's probably not for the same reasons that you think it is. It's probably not for pain. And then, of course, your non-opioids, ibuprofen, IBU. Ketorolac is that Toradol. That's commonly given for kidney stones. And you can usually give it IM, especially if they're in the ER and you don't want to start an IV. You can give it to an IM. You can give it to a migraine sufferer that you want to get out of the hospital, IM as well. But in the hospital, we tend to give it IV for kidney stones if they've had to be admitted. And then naproxen is Aleve, very long acting, very good med. You can only really take 2 a day because it's so long acting. Opioids, pure agonists. They are just blocking up that substance P. And you know which ones these are. We have to talk about them all the time. But again, they're really potent. No analgesic ceiling. And you can give them in a lot of different ways. That patch, orally, IV, rectally. You can do a lot of different things with opioids. And it's often can be combined with those non-opioids to provide a bit more relief. So maybe you can use a little less of the opioid if you're using a non-opioid with it, because maybe combined they'll manage the pain well. And remember, this is a controlled substance. You cannot leave it at the bedside for the patient to take when they're done doing whatever. You have to sit there and with it and watch them do it. You cannot leave these meds lying around the hospital. You have to have it with you at all times, especially if your name is associated with taking it out of the Pyxis. So you always have to be really careful about these. And then there's a database called Cures, where if I'm worried that my patient, as a provider, is getting opioids from other providers, but I don't have access to their medical records, I can go into this database and look it up. So because of the opioid crisis, we have all these systems now, so we're not over prescribing these meds. That's how dangerous they are. Adverse effects of opioids, you guys know all of these, right? And that big one is that respiratory depression. When you have no analgesic ceiling, you can just keep taking the medication and get euphoria. You can keep taking the medication until you literally stop breathing because it keeps doing something, right? Even if it is just side effects, it keeps doing something. And that's one of the reasons why it gets so easily abused. So that respiratory depression, circle that, put arrows pointing to it. You know this. It's very common. And with any kind of dosing, we have to worry about stuff like that. We have to worry about sedation. We don't want them to be completely out of it, lethargic, unable to participate in like their physical therapy consult. We need them to be available to live and keep working with their body. Nausea, vomiting, it's very common. We all know the constipation and the pruritus. So those last three, remember when you have severe pain, you're just going to have to treat them for that stuff because we have to give them something to manage their pain, like pancreatic cancer or even pancreatitis. Those people have so much pain. Sickle cell patients have so much pain. So, and they're usually pretty used to their opioids. So you have to give them a lot. So instead of cutting back on how much opioid we use, we have to treat that nausea. We have to treat that constipation. And we have to treat that pruritus, that itchiness. So always know what you need to do. Going back to respiratory depression, you always treat after they get below around 8 respirations a minute. That's when you act. But if you're noticing at around 10 that they're at 10 respirations, you're not stepping very far away from this patient. You're checking in on them often. You're looking at those O2s. You're making sure they're safe and maybe even suggesting that dilaudid drip might be too much for them. So you're acting on 8, but if it's at around 10 respiratory rate, you're not going far. You're keeping an eye on them. So now we get to, of course, our opioid tolerance and addiction slides, our slow 8. So remember, you have to take opioids in order to get the pain relief. If your Tylenols, your NSAIDs, those aren't working for you. And what we did for a long time is that a lot of our medical professionals thought that it was not a big deal. The pharmaceutical companies told them it's okay. You can't get addicted to this stuff. So people just started piling on prescriptions of these medications. And the more you take for a long time, the more you need. So you become tolerant to it, and then the same amount won't fix your pain anymore. And then the longer you take it, the more it changes like who you are as a person. And so these addictions are pretty intense and can ruin their lives. So you can see pain dose is increased, yeah, but adjuncts could potentially help that, could help bring them back down. And we'll talk about adjuncts. So we're always really worried about tolerance and addiction with these meds, right? But we also don't want to keep our patients in pain because they're worried that they're going to get addicted. Like, we'll figure this out together. We'll, push an extra hour instead of doing around the clock on 4 hours. Maybe we can do 4.5, 5 hours so that they can get a little bit more in touch with their pain and even figure out if they still need that large dose or if they can maybe go half on it. So, like I said, the behavioral stuff that comes up, these people's whole personalities change when they've been on these meds for a long time. And a lot of the time, they're probably trying to get pain control, but they're maybe also trying to get the euphoria from these meds. So addiction from therapeutic use of an opioid is negligible. It's not that many, but it's those that are kind of chasing the high. Those are the ones that we're most worried about. So here's that equianalgesics. When we're talking about opioids, we're talking about what's the lowest dose we can give them and still get the effect, especially if we're going from an IV dosing to oral dosing. So this next slide is actually something you need to know, okay? You need to know these. You need to know which ones are long acting, which ones are short acting. What does long acting mean? What does short acting mean? Because if someone's having pain right now as acute, we're going to probably maybe do more like immediate release or rapid release. But if this is somebody who deals with a lot of chronic pain, we might want a med that lasts a lot longer because we already know what's going on and we're trying to cover that pain while we're dealing with the other stuff that they're in the hospital for. So you need to know this slide. And also, if you guys haven't heard of it, there actually are pain clinics. People will go to pain clinics to get their meds, generally because, a lot of the family medicine folk don't want to prescribe them anymore. And so they'll send them to pain clinics so they can fill all of their prescriptions, but also try and talk them into other types of medications to help bring down their pain levels so they don't have to keep going up, up, up on their opioids. And we'll talk about when we get to alternative therapies. So fentanyl. This is the strongest one. It's like 1,000 times that of morphine. It's crazy strong. And it's very helpful for cancer patients and breakthrough pain for cancer patients. Although I did talk to my friend who used to work on Davis 8, and she said that they don't use it as much now because I think they're really pushing for the alternative therapies to help manage all that cancer pain. But, 10 years ago, they were using a lot of this. It acts quick, but it also leaves the system fairly quickly. So it's one of those ones that you have to keep administering. And with that type of up and down, you have to be very mindful of your adverse effects. That apnea, when they're sleeping, they stop breathing. Bradycardia, all of a sudden their heart rate starts going down. Hypotension, the blood pressure starts going down. CNS depression, like just anything associated with that central nervous system. You got to be mindful of that. And then you can see at the bottom that calcium channel blockers, ketamine, macrolides, which are the like ciprofloxacin, they may increase the risk of respiratory depression. So they're going to make more of the medication stay in the system. So therefore, the effects are going to be stronger. And so therefore, every time you have something like that, you're going to make sure that you have a PRN Narcan or naloxone available. This is what they do with sliding scale insulin. They always make sure that if they have insulin on your MAR, that they also have like dextrose, because if something goes wrong, you have something you can push. Well, this is something you can, squirt, and then you can also give IV. So naloxone will help them stop having the respiratory depression for a certain amount of time. It's not for forever. It doesn't stop everything. You have to keep monitoring them because it pulls the drug off the receptor, but then eventually more drug comes in and it starts to fill in that receptor again. And so now you're dealing with respiratory depression again. So you're going to have to make sure that you are staying with your patient, you're calling for help, and then you're just keeping an eye on them. They're going to have withdrawal symptoms in the midst of that and probably get mad at you. They don't know what's going on. They don't know what's happening. And then they might fall right back into that depression. So you do have to be very mindful of them. And then knowing that there are other adverse effects that Narcan can do, like ventricular tachycardias. So you get those big, wide EKGs, hypertension, hypotension. It can be one or the other. Nausea, vomiting. It's the reversal analgesia. And you have to just stay with your patient and keep giving it. So this is for slow 11. So I'm going to compare and contrast a PCA with an epidural. So of course the PCA is the machine that you set up next to the bed, and the patient gets the little button, and the patient is the only one who gets to touch the button. Their mom doesn't get to touch it. You don't get to touch it, just the patient. And it usually goes into your peripheral IV, could be an upper arm or any IV, but generally usually peripheral. And there's generally a base dosing that is pumped in, and then every time they press the button, a little bit more can go in, and they'll have maybe 10 tries an hour where they can get a little bump of the medication should they need it. Like they're about to get up to go to the bathroom, that's a good time to press the button and get a little bump so they can actually move and get to the bathroom in time. And I've usually given morphine or Dilaudid in the PCAs. Always 2 nurses checking it. You're always checking volume at the beginning of shift and the end of shift. There's a lot of checks and balances that go into using a PCA. With an epidural, that could be because of pregnancy. It could be for anything. It could be for surgery. You use much, much smaller doses, but you're putting it right into that spinal area. So it's very potent. And you have to keep a very close eye on that patient, just like you do with the PCA. So just remember your nursing responsibilities for both of these. Monitoring that respiratory depression, monitoring sedation, monitoring respiratory rate. Remember, you're staying with them if it's below 10, and you're acting on it if it's at 8 or below. And then the itchiness that can come with it because they're getting this medication, so you're going to want to treat that. Or even maybe you can use less of it. If their pain is very well controlled, you might be able to use less, treat the itchiness, and then see if the itchiness comes back because you're giving less meds now. You're going to monitor for the nausea, vomiting. And then this is one that's, you kind of forget, urinary retention. So we know about constipation, but we also are going to witness urinary retention in our patients that are getting a lot of opioids. And they're not putting out urine very often, and they're definitely not putting out the minimum. Remember, 240 for an 8-hour shift. So you're going to keep an eye on that. And this next slide is some images of like where they will stick the needles for these types of epidurals. You'll see that the tubing is usually yellow, and there's usually a dressing that you do not remove. So leave the dressing there. You're just going to make sure the dressing's intact, that there's no drainage, and that if it moves, you're calling someone right away. All right, slow number 7 is atypical analgesics. And these are very important because these are sort of what we're hinging our opioid crisis on, right? We need our patients to have a couple different ways that they deal with pain so that we don't have to keep giving them just one, especially an opioid that's going to have a lot of side effects. So we can try different things. And that's where the pain clinic comes in handy because they'll work with the patients. And it usually revolves around Antidepressants, anti-anxiety meds. There's definitely an emotional component to pain. Anticonvulsants, and gabapentin is considered one of those, one that we give for neuropathic pain, but there's other ones as well. And then even cardiac medications like propranolol, or even clonidine, things like that we can use for pain. Atypical is sometimes mixed up with adjuvant, and they're very similar. Adjuvant is usually where you're giving opioids with the med, and atypical is where you're trying to get pain relief with just that med or maybe an NSAID as well. So clonidine, I don't know, you guys have had alcohol abuse patients, but they'll be on something called a CWA protocol. And a lot of times, because their heart rates can go up and down so quickly, they'll put a clonidine patch on them as one of the ways to fight the detoxing process. It might not be happening as much now, but it definitely was a couple of years ago. And this is a cardiac medication. It's peripheral. It's adrenergic, so it's dealing with blood pressure and heart rate. And for those with chronic pain, it can help reduce it because it's one of those meds that has these odd other side effects, right? The thing that it really can do is if you use it as an adjuvant with a narcotic is that you can give less of the narcotic because this medication keeps that narcotic in the bloodstream a bit longer, so you don't need as much. So we can use it as an adjuvant. We could use it as its own atypical analgesic. I've seen lots of different people use it, and then we've also used it with kiddos. It has a bit of a relaxing sedation side effect to it, and some of our more severe developmentally delayed and autistic kids that I worked with in the pediatric neurology clinic, sometimes clonidine would be something we'd give them at night if these kids were sleeping like every other day or only like 2 or 3 hours a day. We might try something like this because we can use the side effect to try and benefit the child. And again, it's always risk versus benefit. Sometimes families just need something to try something, and melatonin wasn't doing it, and lavender wasn't doing it. This might be one of the ones that we tried. Gabapentin says mechanism of action is unknown. We do have a little bit more understanding of what the mechanism of action is now. I'm sure that you guys know we use it a lot for peripheral neuropathy, right? Hey, because it can help calm the nerves. And a lot of time, there's not a ton of interference of other medications. So you can give gabapentin, you can give it 3 times a day, and you're not really messing up other medications that the patient's getting. So it's a really pretty safe medication. Some people hate the way they feel on it, but most people don't really notice a big change. They just notice that their neuropathy seems to calm down quite a bit. However, you do have to think about those very rare adverse reactions like the suicidal thoughts, depression, dizziness. There's a lot of different ones. So you keep an eye on your patients when they first start this, and you let them know about those kinds of side effects if you're the one that's giving them the dosage for the first time in the hospital. This is an FYI nerve block pump called an OnQ. And it's nice because one of the things that when you receive a patient from post-op, it's nice for them to have a little bit of anesthesia still left in their system, or maybe they're on a nerve block for a little longer, because then you're not giving them a bunch of opioids to try and manage their pain. And you know how strict we are with post-op, get them out of bed, get them walking, get them doing stuff. This can actually help with that. So just an FYI. Also an FYI, we're going to start talking about complementary or alternative medicines. There is a branch at the NIH, which is the National Institute of Health. They're very useful. So we're going to go into a little bit more information about that. AHNA is the American Holistic Nurses Association. A lot of nurses will do double training so they understand how to help somebody holistically as well as how to help somebody through Western medicine. So again, FYI. This is the slide you guys need to know. This is slide for slow 3 and 12. You're going to need to know these. So you're looking at all these different things. Alternative medical systems. So those might include things like teas and vitamins and whatnot. Maybe even scent can be used. You have your energy therapies. You have your exercise therapies to try and calm your soul a little bit. You have your manipulative and body-based methods like chiropractic, massages. You have your mind-body interventions like meditation, art therapy, prayer, pet therapy, nutritional therapeutics. You might be focused on veganism to try and manage things, vitamins, macrobiotics, microbiotics, a lot going on. Pharmacologic, but that are not pharmaceutical. They're more biologic, to like products from bees and things to manage allergies and stuff like that. And then complex natural products, botanicals, herbs. Look at that, shark cartilage. I had no idea. So examples of alternative therapy used for pain, specifically for surgical pain. You can see some of the stuff they try and help these folks so they don't have to give them as much pain medication. For muscle pain, the TENS machine, remember, is vibratory. It's like got two little pads and it like sits there and vibrate to try and give the body some type of relief. Cancer pain, you can think about, scent, relaxation, guided imagery. And then psycho-emotional pain, of course, is very difficult to deal with. A lot of people will overuse medications trying to quiet down their brain, but there are other ways that they can try and do that as long as they have the resources, of course. And what is an example of a mind-body intervention that is considered complementary alternative therapy? Just go back a couple slides and we'll talk about it in class. So if you made it all the way to the end, come up to me and say analgesic, and I'll have something for you. Okay, I hope you guys have a good day, and please keep track of your questions and make sure that you ask them. If there's something that doesn't make sense, I'm more than happy to address it. Okay, thanks.